Hi, this is Dr. Nick. I'm the Incrementalist here with Incremental Insights for better business, better health.
And this is Fred Goldstein with Accountable Health, here helping employers and other companies with their population health programs. So, Nick, we've talked about a lot of different countries around the world, but mostly focused on the United States. But it's really interesting what we can learn that is being done elsewhere, or perhaps some data that comes out of other places. And one of interest recently is Bangladesh. So why don't we start there?
Yeah, so question came up in some discussions with colleagues, friends, as to why, when we look at these countries, we don't see the same incidence. Yet in Bangladesh, as an example, you have a very high density population in a limited geography or space, irrespective of anything else. Living in close quarters tends to be challenging, different socioeconomic. We see this in lots of other continents and countries. Yet when you compare it in Our World in Data, which is a great website for doing comparisons, you look at the incidence as a percentage, you just don't see it. What's going on, Fred?
Well, it's fascinating to think about that because, what are the infection rates, the death rates? Obviously, it's been really difficult, and the world has not done a good job of getting vaccines out to these countries so that they can help protect themselves. I think the most recent I saw for Bangladesh was about 10% of the population is vaccinated. And
Right?
obviously, there's an effort, but you've got to get the vaccine to them to help them out. And so it would be good to see that go up. But it's interesting to see what are potentially lower death rates, lower infection rates. And I'm wondering,
Are
if
they
maybe
just resistant to COVID-19?
you're the medical physician here, and
I
I'm
think
going to
I think
say,
let's
from a
so let's
biological perspective, I would not assume so. People are
no,
people are people,
right.
so I
And
would
I
not.
think we see this worldwide. So let's talk about some other countries and some of the experiences. So India is a great place to sort of focus on because there was a whole period of time. We've seen some different periods in their particular history with this disease. So first of all, worldwide disease. Any idea that you can kind of isolate, due deference to New Zealand and Australia, who have done a reasonable job, but they're a significant island and they're limiting people coming in. But in the case of the other places, it's essentially running through your population. So in the case of India, what we saw was they locked down the country completely. I mean, if you looked at the videos, you saw them. This was, you are confined, and there was challenges with a population that has very limited resources. There was very little in the way of DoorDash or any kind of services for food. And I'm laughing, and I don't mean, it wasn't humorous for them, but um, huge challenges, but they enforced it and very, very rigorously. And they saw almost, I don't want to say negligible, but a very, very low rate compared to other countries that had what I would call a softer lockdown. And I think we saw the same thing in Bangladesh, right?
Yeah, my understanding is they did some serious lockdowns. I mean, you weren't allowed out of your house for extended periods of time. My understanding is also there was a fascinating study done that said, in essence, when you call the lockdown, don't allow the people to disperse back to their homes. They maybe are working in a central city or something, because that apparently allowed for the spread to get out as you lock down. And so I understand they did a number of lockdowns and reopened. They had their schools closed for about 18 months, as I understand. I also wonder if, when you see data that says this was in people who were more well off were infected or had higher death rates, if in countries with really severe socioeconomic issues, if it's just a vast underreporting of the individuals who were not in those groups. And so they're not getting tested. Maybe they're not even getting access to the hospital. As I noted in one of the articles I read, they reported 30 something deaths for the day in Bangladesh, and every death was in the hospital, was a hospital patient. So I assume there were some that were outside of the hospital.
Well, and I think we can safely say that deaths are occurring outside of the hospital. So, are they being reported? Don't have detailed data on that. But even if they are being reported, are they being classified accordingly? Are they even getting tested to link them back and say that this was COVID-19 as a disease? And you make an important point. accessibility to testing. If you don't test, I mean, this reminds me a lot of a very famous book in the medical profession that, still around today. And, don't measure the temperature if you don't want to find a high temperature, or pyrexia, as we call it in the medical profession. Same thing with testing. And I know there's a lot of mis and disinformation around that, and that's why you don't see this and that. But in this case, it appears that there is a low proportion of testing, very low vaccination rate, which clearly needs to be fixed. I think it's not solid data that can be relied upon. Not that there's any discrepancy or attempt to conceal, but there's just not the capacity. And the other thing that you and I both noticed was that I think the largest study, right, on mask wearing was carried out in Bangladesh. That's extraordinary to me. Why is it that country? So were they able to impose or create an environment where people followed it? We see this in Africa, where you have a very strong public health policy that is focused on the community. They don't have the same hospital infrastructure. We saw much less transmission because everything was focused on communication and public health. And part of that was, wearing of face coverings. So they've done a good job, it would appear, but there's also some question of the data and how much it's representative of what's actually going on.
Yeah, and I think it should be pointed out that mask study showed that masks do work. And what would be fascinating to get out of that is, what were the communication methodologies that they used in those communities to create that high level of mask wearing, so we can take some of that and bring it back here and potentially apply it in our communities as well.
Got to be some of that's culture, I suspect, and the willingness and compliance. We see that as a difference. But yeah, there's maybe some communication tactics and capabilities that we can always learn from other countries.
Absolutely. There's a lot of really good stuff going on. And I would hope that over the next few months, we and other countries come together to help not only get them more vaccines, but also the testing, as you pointed out. Because if you could get rapid tests, you consider the percent of that population that does need to leave their house every day just to support themselves, to get food, to earn an income. And if you could put rapid tests out in that community, you could obviously open it up much quicker. So once again, a fantastic week. Thanks so much for joining us, Nick. And this is Fred Goldstein with Accountable Health. If you've got any more questions, please go to accountablehealthllc.com.
And this is Dr. Nick. I'm the Incrementalist, here with Incremental Insights for better business, better health.